Good evening and Happy New Year. I am the Surgeon General for Alpha Phi Alpha Fraternity Incorporated, Dr. Jeffrey Sterling, and welcome to tonight's webinar. We're going to be having a dental health conversation about the good, the bad, and subsequently not so ugly. It's absolutely a pleasure to have this esteemed panel here with us this evening, and even more so to reintroduce our Deputy Surgeon General for dental health, Brother Dr. Langston Smith. Dr. Langston Smith received his DMD degree from the University of Kentucky in 1977. He joined the U.S. Navy following dental school and served fully 30 years on active duty. He completed his dental fellowship in endodontics at the Naval Dental Center in San Diego, California, and a residency in endodontics at the Navy Postgraduate Dental School in Bethesda, Maryland. He is a diplomate of the American Board of Endodontics, receiving certification in 1992. And following his retirement, he served as associate professor and chair in the endodontics department of Howard University College of Dentistry in Washington, D.C. for 12 years, retiring in 2019. Aside from his too many to name awards, he has been Alpha Phi Alpha Man of the Year in 4 different chapters and the recipient of the Eastern Region Alpha Man of Merit. Brother Dr. Langston Smith, welcome. Have a great show. I look forward to speaking to you and the panel at the end.
Thank you, Dr. Sterling. Good evening. On behalf of our Joint President, Brother Willis L. Alonzo III, our Board of Directors, our Surgeon General, and the Deputy Surgeons General, welcome to tonight's Surgeon General's Initiative webinar. Tonight, we will have a very interesting topic that has, over the past few years, received much attention, and that is, my friends, the dental implant. Implants meet the need of replacing missing teeth. Once upon a time, we relied on the complete denture, the partial denture, and the bridge to replace missing teeth. However, recent innovations in clinical dentistry have brought us to where we are with dental implants today. Tonight, we have a very distinguished group of dental professionals with extensive experience in the area of dental implants to discuss this topic: the dental implant, the good, the bad, the ugly. Tonight, they will present a series of clinical scenarios on implants and discuss medical considerations regarding implants, along with addressing some of the misinformation that exists. They will discuss the surgical aspect of implants, and then we will wrap it up with the restoration of the implants. Before I introduce the panel, a couple of housekeeping guidelines. Please mute your devices so that there's no interference during the presentations. And we will have a question and answer session following the presentations. So if you will place your questions in the question space, we will be able to get them answered. And now, I will introduce our panelists and we'll get this discussion going. Dr. Crystal McIntosh. Dr. McIntosh is a full-time associate professor at Howard University College of Dentistry. Dr. McIntosh received her bachelor's degree and her dental degree from Howard University. She received her certificate of residency in periodontics and her MS degree from the University of Detroit, Michigan, University of Detroit Mercy in Detroit, Michigan. She is certified by the American Board of Periodontology, an active member of the American Academy of Periodontology, the American Board of Periodontology, the American Dental Education Association, and Omicron Kappa Upsilon. Dr. McIntosh currently serves as the director of the Division of Periodontology at Howard University and maintains an active clinical practice limited to periodontics at the Metropolitan Dental Specialty in Silver Spring, Maryland. Dr. McIntosh Clark. Dr. Ezra Merritt. Dr. Ezra Merritt is a native of Pensacola, Florida. He completed his undergraduate degree at the University of Florida and a Master of Public Health degree from the University of West Florida. Dr. Merritt received his dental degree from Howard University and completed the general practice residency at Portsmouth Naval Hospital, Portsmouth, Virginia. He completed residency training in prosthodontics at Naval Postgraduate Dental School in Bethesda, Maryland, and a Master of Science degree received in oral biology at the same time. Dr. Merritt is a lieutenant commander, serving as department head and prosthodontist at Branch Health Clinic, Naval Air Station, Pensacola, Florida. Dr. Merritt. Dr. Justin Watson. Dr. Watson is a commander, Dental Corps, U.S. Navy, and serves as the director of dental services, Naval Hospital, Oak Harbor, Washington. He received his undergraduate degree from the University of Washington and his dental degree and the Master of Science of Dentistry in Cardiology and Operative Dentistry from the University of Michigan. Dr. Watson. Dr. Samuel Young. Dr. Young is an assistant professor of oral and maxillofacial surgery at Loma Linda University College of Dentistry, Loma Linda, California. He is in private practice of oral surgery in the San Diego and Temecula areas of California. Dr. Young is a retired Navy captain with over 30 years of military service. Dr. Young received his BA degree from Occidental College in Eagle Rock, California, his dental degree from Harvard University, Boston, Massachusetts, and completed oral surgery residency at Naval Hospital, Oakland, California. Dr. Young is a diplomate of the American Board of Oral and Maxillofacial Surgery and the National Board of Dental Anesthesia. Welcome, ladies and gentlemen. And with that, we will start our discussion with Dr. Merritt, who will discuss and present some clinical scenarios regarding implants. Dr. Merritt.
Thank you for that wonderful introduction, Dr. Smith. I'm certainly excited to speak on dental implants. It actually is about probably 60 to 70% of my dental practice. So it's something that I see on a daily basis and constantly answering questions and inquiries about the dental implant. It's not a one size fits all solution. So with that, we're going to jump into some scenarios to kind of get your mind going on certain options for replacing a missing tooth. Next slide, please. So for our first case, we have a 38-year-old male who presents to the dental clinic with a chief complaint that I have been missing my lower back tooth for 3 years and I would like to replace it. He states that previously he had a very large filling on the tooth that lasted for 10 years, but the tooth fractured and had to be pulled 3 years ago. He has been very busy with work and has not had time to pursue dental treatment until now. So right off the bat, just in taking his dental history, whenever you hear that a tooth has been missing for any period of time over a year to 2 years, I'm automatically thinking that maybe we might have lost a little bit of bone potentially at the site where the tooth is missing, and or the opposing teeth may have drifted, etc. So these are some things that we're already keying into as providers, as far as whether this person is a good candidate for an implant. The next slide, please. So here is a typical X-ray or radiograph. It's a panoramic radiograph, which shows that where the tooth is missing. Next slide, please. So you see here where it's circled, that's exactly where the opposing tooth is missing. Next slide. And oftentimes, especially with technology today, we're getting a 3D radiograph or X-ray. This happens to be a cone beam CT. And for some cases, we really need to get exact as far as measurements go. So on the left side, you have what we term a buccolingual measurement. We also are looking at where certain critical structures are, such as the inferior alveolar nerve, which is what is delineated by that kind of line on the right picture there. So all those measurements are things that, whether you're the surgeon or the restoring dentist, you really want to key in on, because again, if you're deficient in any way, we may have to look into other options or procedures to make you a good candidate for the dental implant. Next slide, please. So these are the intraoral images. So, just kind of imagine, if you would, as a dental provider, you're looking inside the mouth. You want to see that you have a lot of room, right? You want to have a lot of bone, good, healthy, soft tissue, good hygiene. All these things are extremely important. Just like a regular tooth, you're going to have to take care of that implant and that crown because you want it to last, as long as possible. So in this case, you do see what I mentioned before. The fact that that tooth has been missing for some, at least 3 years, that tooth did start to drift into that empty space. So what does that mean? Well, depending on the measurement, we may have to, determine whether or not we can still place the implant. Is there enough room for the crown? There are minimum guidelines that we have to meet. And so those are the types of things that, a restoring dentist and or the surgeon can talk to you about during the exam. So biggest takeaway from this particular case is, we have to have the enough room to actually get a crown back there. And if you think about it, the further back you go in the mouth, the less room potentially you'll have. Next slide, please. Next slide. Thank you. So for our second case, very briefly, so we have a 52-year-old male who presents to the dental clinic with a chief complaint that my tooth was pulled a year ago and I want a dental implant. The patient's medical history is unremarkable and he is not currently taking any prescription medications. So for this particular scenario, I wanted to kind of key in on the fact that we do have to take a look at your overall systemic health and whether or not you are a good candidate for surgery at all. And so that's something that we're going to touch on in the next section. But next slide, please. So here you have another panoramic X-ray. Just shows the full mouth there, and the missing tooth, as you can see, is on the patient's upper right, but you can see where the tooth is missing. In this particular case, this patient has a history of having a couple of dental implants, as you can see there. So he should be, well versed in kind of the procedure. The implants look great as far as the bone level, so that is a good sign that the implant that's placed can be successful. Next slide, please. So the one thing I wanted to bring up in this particular scenario is the fact that there are other options. And so the general dentist or the restoring dentist will walk you through step by step what your options are. In this case, I'm showing a traditional 3-unit bridge, which literally bridges the gap. We're not going to go into a lot of detail because this is the implant presentation, but there are pros and cons to each restorative option. That's really the biggest key takeaway here. Next slide, please. So, and this is just showing, again, just a quick graphic of the actual implant in place, and just a digital graphic there, and the future crown. A lot of times as a restoring doc, I'm doing all the measurements on the computer, making sure that, again, this is a good site for a crown. Next slide, please. So just wanted to show again, we have to do measurements to make sure that we have the minimum amount of space, the width, the height for a future crown. And in this case, luckily there's opposing teeth and it doesn't appear that they have lost any width or room for a crown. So for this case, just thinking about from the surgical perspective, making sure there's enough bone, height, width, but also making sure that there's enough room for the crown. So without going into too much detail, there are options as far as material choices and things of that nature that that the dentist will go through with you. Next slide, please. So the key takeaways from these two just very brief clinical scenarios, not every scenario is ideal for a dental implant. There's going to be times where you go further back in the mouth and there may not be enough room for the surgeon to actually get back there to place an implant. And, there's plenty of times where I'll have a patient in what we call first molar occlusion, where we do not replace a second molar if it's lost. There are minimum measurements that must be met, and that's because of critical structures and the materials that we use. They have to meet a minimum standard so that they don't fracture on you. Often when teeth have been missing for multiple years, as you saw in the first case, you can lose, the teeth can drift, and oftentimes there's loss of bone. And so any active disease, any cavities or periodontitis, actual bone loss needs to be treated first before we're going back and placing an implant. So all these things you have to follow the correct order. So those are the key takeaways from these scenarios. Next slide, please. So I'd like to present Dr. Watson, who is going to present on medical considerations and misinformation.
All right. Okay, here we go. So we decided that we're going to get an implant. You went to the dentist. Dentist said, let's go ahead and do the implant. You agreed for the dental implant. What are some of the factors that can contribute to success that are in your hands as the patient? Next slide, please. Medical considerations, your systemic, what's going on in your body? I have, these slides are animated, so I need you to kind of like, I'll just like say click. Yeah, there we go. Your health matters. Click. This is going to be obnoxious. Smoking. Smoking is one of the #1 reasons for failure of a dental implant. Diabetes is also one of the large indicators. Go ahead and keep clicking. I think we got two more. One more click. There we go. So smoking and diabetes, top 2 contributors to failure of an implant due to the patient's health. Osteoporosis, heart disease, and hypothyroidism also play a contributing factor to the success of an implant, but I'm going to go ahead and just talk about the 2, smoking and diabetes. So smoking, go ahead and click like 3 times, I think. I don't know. We'll see. Just keep clicking. Click, click, click. There we go. Let's go there. #1, you need to quit smoking before you get an implant. Easy, right? I know it's not that easy. Someone that smokes has been smoking for a long time. It's a hard habit to stop. The reason for not smoking is nicotine. Nicotine leads to poor healing with carbon monoxide that is in your cigarettes and cigars. That also leads to poor wound healing. One study stated that you have a 2.5 times increase failure rate for patients that smoke. One of the comments in the section stated, why are dental implants so expensive? Yes, dental implants are very expensive. So if you have a 2.5 better chance to make this thing stay in your mouth, because you will pay for it regardless if it succeeds or not succeeds based on a biological failure, it might behoove you to stop smoking. Another study states that 11% of failures for smokers versus 5%. And if I'm being completely honest, as a healthcare provider, I don't want patients to smoke, but as a realistic human, I understand that people smoke. And so the bullet that says there's no difference in bone quality. So there is no difference. If I were to pull out somebody's jaw of a smoker and I would pull out the jaw of a non-smoker and I would cut it up, you would be able to see no difference in that material. However, it's all about the wound healing. When a titanium screw typically gets placed into the jaw, we need a biologic response to allow that screw to integrate into the bone. And that's what smoking inhibits or stops from happening. And there are some studies in the dental literature that show there is no difference in the failure rate with smoking. But again, I go back to the comment in the chat section where someone said, why are these so expensive? If you're going to spend the money to get a dental implant, it might behoove you to try to stop smoking. And because these slides were kind of edited, the formatting's off. There's a red bullet at the very bottom, which is probably the most important part of this slide. It says that if you are to get an implant and you are a smoker, it's best to try to quit 1 week prior to the implant being placed and 8 weeks after the implant being placed to allow that newly placed dental prosthesis to integrate into the bone and for the body to heal around it. Next slide, please. And the next big topic for your health is diabetes. Diabetes is prevalent in our culture. And again, diabetes is going to affect the ability for the body to heal around the implant. Um, Diabetes affects the osteoblasts. Osteoblasts are known as the bone cells. Osteoblasts, they allow for the body, the jaw, to start building new bone cells into that space, those micro gaps between where the screw was placed into your jaw and where that to fill that space so that it's really solid inside your mouth. Um, and the positive stuff, not all doom and gloom. If you are a controlled diabetic, you have a 94% success rate. That is just as high as anybody else. Um, Another study showed that you have an 88% success rate when you're controlled. So these are pretty good numbers as long as you are doing well in controlling your diabetes. And again, some of my bullets got cut off. If you have an A1C level of less than 7%, and I believe it's 6% for your HbA1c. But these are numbers that you can easily Google if you're interested in knowing what numbers you need to have to make sure that you're giving yourself the best opportunity to have success with your new dental implant. Next slide, please. So misinformation, we're changing lanes a little bit. Truth and lies. Next slide, please. Have you ever been driving down the freeway and you've seen advertisement like implants, 199, 398, whatever it is, and you're like, wow, that's a great deal. Well, it's not being 100 with you, right? So go ahead and click a couple times. So the first bullet, man, I lost a lot of my information. Okay, the first bullet, not all implants are the same. So manufacturers have different standards in the alloys and the machining when it comes to manufacturing, creating these dental implants. Just like a lot of off-market products that are out there, some of them are just as good, if not better than the original. But I would, if I were to do a procedure for a family member, I would want to make sure that the materials that I'm using is a name brand, because the name brand tells me that there's someone standing behind that product. And so when you get into an area where you're maybe offered a very cheap implant or an inexpensive implant, you might want to ask your doctor, ask your dentist, hey, what's the brand of this implant? And then you can go home and get on Google and see if this is like a normal run-of-the-mill, one of the top 5 dental implant producers, and you can feel confident that you're getting a good product. If he can't tell you, or if he says it doesn't matter, you might want to find a different dentist. And then also with that advertisement of a inexpensive implant, they may tell you that this Mercedes Benz is only $3,000, but we're gonna go ahead and charge you like $60,000 for the tires, and you're still walking out paying for a $60,000 car. And that's kind of the similar setup with this advertisement scheme, is that regardless of what they're going to charge you for the screw, they're going to get you with the crown. And so you're going to walk out the door paying $2,000, $3,000, $4,000 for a dental implant. And just to address the comment that was in the section earlier, why are they so expensive? There is materials expense, and then there's expertise expense. And so another question you can ask your dentist when you are engaging in the idea of getting a dental implant is, where did you get your training? I can tell you, these members on this panel, a lot of money was invested in their education, and not everybody, this is a skill that not everybody has, and that's part of the cost of a dental implant. I think that's all I have on this slide. I'm not sure, but let's go on. Yes. And my last little bit of misinformation. Go ahead and click. Implants are not real teeth. And if I could really drive this home today, and I believe the next presenters will also drive this home, they are teeth replacements. I have patients come into my practice say, "Doc, let's just take all these teeth out and let's just do implants." Implants don't have the same feel as your normal teeth. And what I mean by that is that there's a little arrow pointing at that tooth. And if you could take a marker, and I asked you to follow the little black line that traces the outline of that tooth, you would be able to do that pretty easily. Inside that little line is something called the periodontal ligament. That periodontal ligament acts as like a shock absorber, and it gives you sensory feedback. So that's why when you're eating popcorn and you accidentally hit a kernel, something goes off in your brain saying, I probably shouldn't be chewing that hard. And it allows you to preserve your teeth by not putting max force on your tooth and just fracturing your tooth. With a dental implant, there is no periodontal ligament and there's no sensory feedback. So although dental implants are great for replacing that space, they are not quite apples to apples. That concludes my part of the presentation. I would like to go ahead and introduce Dr. McIntosh and Dr. Young for the surgical component of this.
Dr. Young, you're muted.
Thank you very much, Dr. Watson. I am Sam Young, oral surgeon, and I'd like to talk a little bit about the prerequisites of what is needed prior to placement of an implant. Next slide, please. Here is a great example of the types of cases that I see, and I'll point out a few things in this slide. As you can see, most of the upper teeth, basically all of the upper teeth, are hopeless and they all will be lost. And in a case like this, the person does want to have replacement teeth and they're not interested in wearing a denture. So we have to ask the questions: what type of bone and what quality of bone, how much bone is needed so that we can restore this person with implants, and is that even possible? On the upper left side, we can see that there is a large amount of bone loss, which is why these teeth are quite loose and they will be lost. And we have a very important structure, the maxillary sinus, on both sides that will be violated because there's lack of enough bone. There are some vital structures also in the lower jaw. And in this particular Panorex, they show very well this nice black line that runs through here is the inferior alveolar nerve, and we want to avoid that at all costs, okay? Because we do not want the person to end up with numbness in the lower lip, okay? Next slide, please. Here we have some specific guidelines and measurements for implants. Dr. Merritt spoke on that a little bit, and he showed good examples of case where there was not enough restorative space to replace the area with an implant. The measurements here shows that we need to have at least 1.5 millimeters of space between any real tooth and the surface of the implant. And between implants, we need to have at least 3 millimeters of space so that you can have space to actually build the tooth structure itself. In addition to that, we want to have at least 2 millimeters of space between the end of your implant and any vital structures, such as the nerve that runs in the lower jaw. We want to have at least 1 millimeter to 2 millimeters of space on the outside and on the inside of the implant as well, so that it can properly integrate into the bone. Next slide. Here we see an example of an area here that needs to have an implant. We want to replace this cuspid, and we have a little ruler here to show the measurements of the space there. We want to have at least 5 millimeters of space between the gum tissue and the lower tooth so that the proper size tooth can be made. If you don't have that much room, then you need to create it by either lowering the bone, or it's not a good idea to shave off part of the lower teeth. Minor adjustments is okay, but no major adjustments, okay? We want to look at the smile line to see how that's going to look once the implant is replaced. We want to have good attached gingiva, that's the firm gingiva around the implant, so that it looks natural as the tooth comes through. Once again, we're measuring the width, the length, and the height of the space there, and there is a minimal requirement of space there in order for an implant to be placed. Next slide. Here's an example of a person who had a tooth removed here on the lower left side, and you can still see the outline of the tooth, which is an indication that maybe there has not been enough time lapse for the bone to remodel properly, which brings up the question, when you do have a tooth removed, is it necessary to have a bone graft at the time of extraction? In some cases it is, in other cases it is not, based on how easily that tooth came out and how much bone is destroyed. If lots of the cortical bone is lost and you have a limited space, then you will want to graft that to replace the bone that has been lost, okay? So that speaks to the importance of taking out a tooth as atraumatically as possible so that you do not lose the bone, okay? On the other side, on the patient's right side, we can see that the bone is really well preserved. The bone height is good, and there is adequate space to have an implant placed there. Next. In this slide, I wanted to show the upper jaw, a totally edentulous person who wants to have implants placed. On one side, we have good bone, and we will be able to put in implants here to help with stability or even to do a full mouth reconstruction on this case. However, on the left side, you can see that the sinus has pneumatized and moved all the way down so that there is not enough bone here to properly put an implant. And in a case like this, this would be a good indication for preparing that space properly by doing a bone graft. And there are various types of bone grafts that we can do to restore this, which is probably not appropriate to talk about those now, but it is possible to fill this whole space up and let it sit for approximately 6 months until the bone remodels, which would make this a great area to place implants. Next, we are going to talk about implant placement itself. And for that, Dr. Crystal McIntosh will start the discussion on placement of implants. Dr. McIntosh.
Thank you, Dr. Young. Good evening, everybody. So now we have bone. We have a good space in order for us to actually place our implants. So on the day that you actually come for your implant, there are a couple of things that we're still going to go over. And one of those things is your medical and dental history, of course, making sure that you have no systemic conditions that we're unsure of, any medications that you are taking. We want to make sure we have a proper log of that. Once we have that, then we'll have you sign the consent. On the consent, it will let you know that we're placing an implant, and then we'll also talk to you about the possible complications that can occur after implant placement. Most of the time, most of those complications are probably about 1 to 10%. Doesn't really happen, but we still discuss them with you. For your prep for surgery, of course, we have to give you local anesthesia. This local anesthesia will numb up the area nicely so that you don't actually feel when we're doing the procedure itself. So when we're doing the procedure, we are going to make sure that we do a small incision so that we can open up the tissues so that that implant can be actually placed. Can you go to the next slide, please? So if you can see here, basically the area is numb on your left-hand side. We've opened up the tissues and we've done a couple of drills and we've placed our implant and then we close it up. Okay. And so when we close it up, we're of course going to give you some instructions. If you can go to the next slide for me, please. And those instructions, one of them definitely I know everybody wants to know is pain management. What will we do in order to make sure that you're not uncomfortable? And of course, prescribing ibuprofen, Tylenol, aspirin, or tramadol. There's a list of things that we can actually do in order to make sure that you are comfortable after the procedure is done. As far as making sure that the bacterial level stays down low, and we can also give you a mouth rinse that always helps keeping the bacteria low, and or an antibiotic. Okay, so antibiotics, as we all know, are used to help keep that infection level down low. And those are that's one of the things that I would say is probably a complication, if anything, is just making sure that we keep that bacterial level down really low. Okay, next slide for me, please. And of course, we always talk to you about our post-op complications. As far as post-op complications, we talk to you about your post-op instructions, what we want you to do in order to keep this area clean, keep it safe, and when I say keep it safe, keep it from any harm whatsoever. Okay. And so what we ask for you to do as clinicians is to make sure that you follow the guidelines as closely as possible. And if you have any questions whatsoever, please feel free to talk to your clinician. Don't try to mull over it yourself. Always contact us and let us know. So, of course, making sure that you have your medications. The day of the surgery, after it's done, we'll ask you to place an ice pack on the area just for that day. And then, of course, you want to keep your mouth clean. However, in keeping your mouth clean, that does not mean we want you to brush the area because that area is going to be sore. So we ask you to avoid brushing that area, but going to brush all other areas of your mouth. This within itself helps the body out. Eating food. I know a lot of people are probably wondering, what can I eat after I have this surgery? Well, you still can have a decent meal. However, that meal will be a softer diet. Okay, so your good foods will be like your milk, fish, eggs, soup. I know on here it says baby food. I don't think that you want to actually try that, but that is an option for you. Okay, bleeding. I always tell patients there is always a chance of oozing. Sometimes when we're eating, we kind of hit that area and it can ooze a little bit. I don't want you to panic. That is a normal thing. Okay, don't rinse the area out because that'll kind of pull all of that blood out. Just kind of stop, take a wet tea bag, wet it, and then put it inside of your mouth and kind of hold it there for a little bit. Applying that firm pressure can kind of allow the body to say, okay, there's no other harm being done here. Let us just try and clot up again. And that's what we need. So we don't want you to fiddle with the site at all. Any sutures that are placed, please come back to the office and allow us to take those sutures out for you. And yes, definitely Dr. Watson talked about this. Do not smoke. Smoking is a pure way of making sure that our implants will fail. So please mind those things. Next slide for me, please. So here, I kind of want to touch on one of the cases that I had. And that case failed just because of communication. We had this patient walk into the office. He was 63, pretty sizable guy, 6'6", had 385 pounds. Next slide for me, please. He had high blood pressure, also a sleep apnea. Next slide for me, please. And when he came into the office, the idea was for him to actually have implants placed in the area of 27 to 30, also with the extraction of a wisdom tooth. Okay. He had previous work that was done in the office and everything else went fine. Next slide for me, please. His medications, he was taking high blood pressure medication and then he was taking medications for motion sickness. Next slide, please. So this is him. Basically, when he walked in, we took a Panorex radiograph and you can see where he would need to have his implants placed on this right-hand side. Okay, next slide. So on the day of surgery, like I said, we numb you up. We actually make a small incision. And in this particular case, I actually used a guide. Because he had to have so many teeth placed, I wanted to make sure that every implant was placed in its proper position so that my restorative dentist would be happy with its position as a whole. Okay, so next slide for me, please. We placed the implants, and as you can see here, the implants were surrounded by solid bone. So we were very happy with the result of that. Next slide, please. And we gave him his post-operative medications, his mouth rinse, antibiotic, and his pain medication. Next slide, please. We also talked to him about how we wanted him to heal. Not really something that I will go over here, but these are the phases of healing. Next slide, please. And when he came back, his tissues weren't exactly how I wanted them to be 1 week post-op, but I ended up giving him another dose of medications. What I noticed here is that his tissues were a little bit more inflamed than I wanted them to be. So I did talk to him about how he was taking care of the area, and he assured me that he was doing what he needed to do. Next slide, please. Other way, please. No. You go forward. You're going backwards. One more, please. One more. Okay. So now when he came in at 4 weeks, when we actually pushed on the tissues, what we noticed is that he was in an extreme amount of discomfort. And he was actually having a bad taste in his mouth. Pus was coming from the site. So we decided to, next slide, please, look at the radiographs. Now, when you look at the radiographs, you can see that there was a severe amount of bone being lost around those implants. And to us, it was a matter of why was this happening to him now? So needless to say, we still had to take out those implants that were very badly infected. Next slide, please. So here you can see the implants. They were so mobile that you could literally just pull them out because the infection was so bad. Next slide, please. And here you can see how much bone was actually lost around the implant. Next slide. And how much we had to do in order to clean those areas out. And so when cleaning those areas out now, we also have to consider how are we going to preserve this bone for any future placement so that the patient can have the implants that he also desired. So bone graft would actually be placed in this area again now. Next slide, please. So here you're just seeing the bone that we placed back in the area. And you can also see that we actually left one implant because at least that one was more salvageable than the rest of them were. Next one, please. Next one. Okay. And so here we actually put this patient on a course of antibiotics again, mouth rinse, Motrin, and then a heavier dose of pain medication. Okay. Next slide. And so, of course, like any good clinician, and I think all of us would definitely do this, you mull over what happened. What is it that was possibly missed during your consultation with the patient, during the surgeries, because we had done previous surgeries on him and he had no complications whatsoever. So next slide, please. So I actually went through a list of things. Was it the operator? Was it me? Was there something that I did wrong? Was there a lack of blood supply? What was it? After further investigation, we actually found out that this patient was a diabetic. He never divulged the fact that he was a diabetic to us. He pretty much kept it under wraps, and he said it to me later on. He said, "Doc, it's not your fault. I'm a diabetic, and maybe I should have told you that." So as Dr. Watson said before, it is very important for you to tell us what your systemic condition is like. This allows us the ability to be able to assist you and make sure that your implants survive and that you don't have to have any subsequent procedures done after the implants are placed. Okay. Next slide, please. Next slide. And who I would like to present back, Dr. Merritt, so that he can talk about the restorative aspect of the implants.
Thank you, Dr. McIntosh and Dr. Young. That was a great presentation. Next slide, please. All right, so we're going to start on the restorative phase now. So congratulations, you made it to the finish line. The implant is fully integrated, and so we're ready to try to get you a crown to replace that tooth. So we're going to go through the steps of restoring the implant. What are some realistic timelines? And very, very briefly, I'm going to touch on the material choices that we have for that particular crown. Next slide, please. So we're going to start with the final impression. Okay, so we have so much technology at our disposal now. We have what's called CAD/CAM, which is digital dentistry, where you can do intraoral, have a camera and literally scan the teeth with the camera. The image pulls up on the computer. We design everything, but we still have our analog way of doing things, which I term traditional. And I'll show you both those methods right now. Next slide, please. So for the digital impression, again, I'm a military provider, but a lot of civilian offices also have this setup as well, where they have what in this case is a CEREC OmniCam. There's dozens and dozens of companies that have their own version of a computer-based system with an intraoral camera. And then on the left, on top of those cabinets, you have what's called a 5-axis mill, where they literally in that office can mill the crown same day potentially. It just depends on the flow of that particular office. So this is kind of the typical setup that you'll see in some offices. Next slide, please. So you come to my office, I sit you in the chair, we kind of review. You saw some photos previously. I apologize, I don't have them in my slides, but when you come to the office, you'll have what are called healing abutments. So those little metal caps that were sticking up above the gums or the gingiva are called healing abutments. So when you come to me, I will remove that, place what's called an impression coping, and then either do a digital scan, intraoral scan. And what you see on the screen right now is exactly what I would do in the office. I would design, I have basically where the implant position is based on that scan, and I can design a crown right there. I mean, it's actually amazing the types of things we can do and how quickly we can do them. But this is an actual screenshot of what I would do to design a premolar crown or restoration. Next slide, please. Or you have the traditional impression. So a lot of us grew up having to have all that, goop and stuff in our mouth. We still use that in some cases, or in a lot of cases, where you take an upper and lower tray, you'll fill it up with typically what we call a polyvinyl siloxane, which sets up in about 4 to 4.5 minutes. And again, the whole purpose of this impression, whether it's traditional or digital, is to get an exact position of the implant, because we need to send this information to the lab or to the computer or what have you, so that we know exactly how much room we have and where the implant is positioned kind of in space. Next slide, please. So this is typically with the traditional impression, you're looking at pouring up these models. So these are the stone models that I would be handing over to my lab officer or sending off to a civilian lab potentially to make the crowns. So you can kind of see the little gold area. Those are what are called implant analogs, but that's an exact replica and pretty much what it looks like in the mouth of what the implant is. Again, there's dozens, really thousands of implant types, as Dr. Watson said, as far as the brands and things like that. But for the most part, there's only a few design types for kind of that internal feature of the implants. So again, typically depending on the type of material that you're using, we would be able to send it off to either to the computer to design, or in some cases we're literally waxing up by hand and casting in gold, because we still do use gold and other metals as well. Next slide, please. So at the same time, so this is all done in the first appointment when you come back to the restoring dentist. Now, if you decide that you want a tooth colored restoration, right, or tooth colored crown, which most of us do, but there are those, and I deliver gold restorations all the time still today. We will do a shade match. A lot of times I'm taking photos just as you see in this picture so that I can communicate better to the lab. Um, in this case, this particular patient does not have a lot of what we call characterization. Some people come in with maybe some white spot staining or some fluorosis. They may have, towards the what we call the neck of the tooth, kind of towards the gums, um, maybe a little darker, and then it kind of transitions to something whiter. We're trying to match perfectly, and typically a good lab can match the adjacent teeth. So I'm taking photos, I'm communicating with the lab to do that. Next slide, please. So at that point, we've ended the first appointment. So typically, it's a 2 appointment deal. There are times when it depends on the practice that you can do a same day crown. It's not a 30-minute type situation. It usually will take a few hours. So most civilian offices, I would say, will not necessarily block off that much time. So you can pretty much bank on a two appointments. Now the timelines could vary whether or not that particular office has their own setup, a digital setup where they can fabricate these crowns in house. A lot of times they are going to be sending it out to an outside civilian lab or dental lab, and so it could be anywhere from a week to 3 weeks as far as how long it'll take to not only fabricate the crown, but then also the clinic's availability to get you back in for the delivery appointment, which is the second appointment. So again, depending on the dental clinic's access to care, how long it'll take to get you back in for delivery. The material choices. So the tooth colored crowns that we talk about are, ceramic. Those are the ones that we can mill. We still do gold, like I said. And so that will take kind of an old school method, just like how you cast or how a jewelry store will cast a ring and other jewelry. It's the same process that we do within the dental lab to fabricate a gold crown. So those are still being done. Now, I don't have a slide on this, but I did want to touch on the fact that a lot of times we hear about the crown in a day, right? Or where we get do the impression, the surgery, and everything same day. So there are times when, speaking about a single implant, where if it's especially a front tooth or an anterior tooth, we will do an immediate provisional. So it's not the final crown or restoration, but we will make sure to provide you a full contour, an actual tooth that looks similar to what the final will look like, but it's kind of a case by case basis, and that's that communication piece between a lot of times between the surgeon and the restorative provider. But I do a lot of same day provisional restorations in my practice. Next slide, please. So these are just examples of final restorations. In this particular case, the technical term would be a cement retained but screw retrievable crown, right? So you see that you could see the screw through the crown, and that's what basically secures the crown to the implant. There are times where we'll do just a cement retained crown, which will not have the hole on top. Now, every office is different, every situation is different. This is my preference, mainly because you can control the cement, and that typically, we didn't go into it in this particular presentation, but a lot of times when implants fail kind of long term, and are ailing, you have bone loss. When you remove the crown, a lot of times there's some excess cement somewhere. So this particular design allows you to control the cement and keep it nice and clean. So this is what again, if I can help it, I prefer doing some sort of screw retained or screw retrievable restoration. Next slide, please. And I wanted to show you a picture. Again, this is on the on the model or on the stone model of a gold crown. And this is one that I just delivered maybe a few weeks ago. So patients that already have gold crowns, or they have a lot of, let's say, silver or amalgam fillings, or a screw retained restoration such as this, if there's limited space, a lot of times you can actually get away with still restoring the implant because there's less space required. So there are times when I will let a patient know, hey, if you want to restore this implant, this is really the only material choice we have based on the limited amount of space. So just so you know, for those who do have a preference, gold is still the gold standard in dentistry. And so, again, I still do it quite a bit in my practice. Next slide, please. And that's all I have for the restorative phase. And I'll turn over the presentation back over to Dr. Smith.
Okay, thank you very much, doctors, for that very interesting discussion. I'm sure that our audience have been educated and hopefully many of their questions have been answered. I will now invite each of you to give just one tidbit or two tidbits of information that you would just like to share with our audience about implants. Dr. Merritt?
Yes, sir. So I actually was looking through the comments. I saw one question that I can address. They talked about, can a current denture wearer become a dental implant candidate? So I think between my presentation and I believe what Dr. Young talked about, yes, you could potentially be a good candidate for implants, but again, it's a case-by-case basis. What we talked about is there's minimum requirements as far as the amount of bone that's needed, and a lot of times, if you've been a denture wearer for 5+ years, it's been an extended amount of time. A lot of times you are a little deficient with bone, and so that may require some sort of bone graft or a procedure to gain that bone. But it is potentially an option and something you could and should look into.
Okay.
I guess the second thing I would say, as a restorative dentist, an implant isn't the catch-all. We still want to preserve natural tooth structure. We want to preserve the teeth as much as possible. So if you come to me and I'm evaluating a tooth that can potentially be saved via a root canal and what we call post and core and a crown, and we can at least maintain it confidently for another 5+ years, that is going to be what I will try to push as the first option. Again, an implant, there is still maintenance. It's not a forever restoration. So when you deliver the crown, you're still going to want to do your 6-month exams or cleanings and your annual exams and things like that to just make sure that the overall health of that implant is still solid and the crown is still good to go. One of the most common issues with the crown, which is very minor, but sometimes they can become mobile over time, and it's just a matter of going back in and tightening the screw. But I just want folks to understand that it's not a once I get the implant and the crown, that's it. You still have to monitor it and do your due diligence with hygiene and things like that. Thank you, Dr. Smith.
Thank you, Dr. Merritt. Dr. Young, any
Yes.
two tidbits that you would like to share with our audience?
Well, number one, from a surgical perspective, the most important thing is to be working with your restorative doctor so that you can place the implant in a place that can be best restored. Back in the day, implants were placed where the bone was, and not enough attention was placed on the restorative factor. But now I always work with my restoring doctor so I can make sure that I put the implant with the proper angulation and in a position where he can best restore it for the best benefit of the patient. So with that, I think that's the most important thing. And as far as medical conditions, there are very few medical conditions that would precludes you from having an implant placed as long as you are under control. There was a question about hypothyroidism. There is no contraindication for having an implant if you do have hypothyroidism. The literature shows that there is no differences in the success rates of implants with folks with hypothyroidism.
Okay, thank you, Dr. Young. Dr. McIntosh, you're muted.
Yes, sorry. Thank you. So, as far as what Dr. Young said, I agree with that, especially the medical aspect. It's very important to make sure that you are transparent as possible with your medications and your status, your systemic status. I see that hypothyroidism, yes, does not stop you whatsoever from actually getting any implants. Now, as far as the pre-diabetic level, I normally treat my pre-diabetic patients as if they are a diabetic patient. Doesn't normally stop you from getting any implants. However, like Dr. Watson had presented before, that is just something that I pay attention to closely. So every time I see you, I'm always looking to make sure that there's no downhill factor as far as your implants are concerned. So it does not stop you whatsoever. Okay. So, but yeah, I don't have any other tidbits. I think the other two gentlemen kind of covered everything.
Okay, well, thank you. Thank you very much. And since we were getting into our question and answer phase, here's one that came in, and it deals with implant retained dentures. What are the pros and cons of implant retained dentures? Since that's a pros question, I'll go to Dr. Merritt with that one.
All right. Yeah, there are certainly pros and cons, but I would say if you are trying to decide between, a traditional complete removable denture or even a partial denture and something that's implant retained, you're typically better off doing something implant retained if you're a good candidate. I guess cost would be one, negative, but I don't see too many other negatives to having an implant retained denture. You don't have to worry as much about retention, right? So it's being held in pretty well with the implants. You're also able to maintain the bone, so that is another benefit of an dental implant over something removable. You don't have to worry as much about bone resorption, right? So or bone loss. So to be honest with you, other than the cost, can't think of too many negatives or downsides to doing an implant retained denture or an overdenture or something like that by just something removable. So if you're a candidate, potentially I think that would be a great option for you.
Okay. All right. Another question. What is the timeline from initial consult to delivery and cementation of the crown? What's the projected timeline for that?
I'll answer that. From the initial evaluation and determination that you are a good candidate for implants, for me, I like for my lower implants to sit for 4 months before they're actually restored. And that's for maximum osseointegration. And in the upper jaw, I like for my implants to sit for 6 months for complete osseointegration before loading them. That can change a little bit based on the quality of the bone. However, for maximum success rate, those are the guidelines that I use and recommend.
Okay.
I have done quite a few of the denture retained implants, usually with the 2 implants. I think one of the slides that I showed 2 implants there. And I think there is no comparison between an implant retained denture versus a regular lower denture, because that little bit of stability holds that denture in place so much more, and people can function better, chew better, articulate better overall. And in cases where there is a minimum amount of bone, there's a solution for that too. It's called bone grafting, which is what I do a lot of. And ultimately, the bone grafting could add an additional 4 to 6 months into that equation.
Okay.
That's it.
All right. Thank you. Now here's one that I haven't gotten before, and that is, will implants cause alarms to go off if I go through airport security?
I don't think so.
Absolutely not. Absolutely not.
I don't think so at all. I think that you're perfectly fine going through the airport. You will have no issues with airport security.
Okay. And we have a couple more questions before we go. How does osteoporosis impact or affect one's ability to get an implant?
That's a good question. Once again, the evaluation of the quality of the bone and the amount of bone is the more important thing. If the bone quality is poor, then of course it means that the implant would have to stay in place longer before loading it. However, in most cases, you can still put an implant in a patient who has osteoporosis without any problems, as long as there is enough width and height. Okay. In those cases, I would look at trying to put the largest diameter implant in without compromising the bone, because that would cause the implant to be more stable. Okay. So we're looking at the width of the implant more so than the length of the implant.
Okay. All right. Another question we received. We've talked a lot about bone grafts. And so one question is, where do you get the grafted bone from?
You want to go?
You can answer that.
Okay. Well, there are a number of places to get it. You can get it from your jaw itself. There are aspects where probably Dr. Young more or less gets it from. You can get it from your hip. But I think most patients that I have pretty much like the fact that I can get it from a vial. And those in the vial are still very safe. They've gone through a number of processes so that they do not cause any infection within the patient itself, and the body does not reject it. So that is another aspect of you being able to obtain a bone graft.
Okay. And I don't, yes, you may have answered this in the discussion, but this question is, how soon after an extraction can the implant process begin?
Once again, I like to wait for 4 months on the lower jaw, 6 months on the upper jaw, just to make sure that we have the maximum bone regeneration and turnover. So 4 months on the lower jaw, 6 months on the upper jaw.
Okay. Right. Well, I think we have several other questions that have come in, but we are running out of time for the questions that for our webinar tonight. And there's one question that I think we can try to squeeze in here. And this is an individual who is starting the implant journey, but she has to wear braces on the lower teeth because of drifting of number 3. And is it normal to have to wear braces because of the drifting before you start the implant process?
So I guess I'll tackle that one. So similar to some of the photos that I showed in the beginning, depending on how long a tooth has been missing, it is normal for teeth to drift until they meet some sort of resistance. So that could be drifting into kind of the adjacent space and kind of in the what we call mesial distal direction or horizontal direction, or it could be drifting down until it meets resistance. So a lot of times, if a tooth has been missing for a while, or if there's some malocclusion or crowding, a lot of times, yes, you do need to do orthodontics, whether that's traditional braces with brackets and arch wires or Invisalign to create that minimum amount of space that is required. One thing to think about with that question, which is a really good question, an implant doesn't move like natural teeth. They can't move. So one of the things in my evaluation if there is any crowding, or if you have a desire to straighten your teeth at all in the future, a lot of times I'm suggesting, hey, you probably want to do that first, because once that implant is locked in bone, that can't move. So you'll just have to move teeth around it, and sometimes that's not ideal. So it's a good thing that you're doing everything in the right order, and hopefully you'll get a great result.
Thank you. And I want to thank you, doctors, for participating in this discussion tonight. And it has been most enriching, and it has been most informative. And thank you for sharing your expertise. You have been great panelists, and we truly appreciate your willingness to share this expertise with us and with our audience. Ladies and gentlemen, thank you for your attention this evening. We have enjoyed putting this webinar together, and I hope that you are a little bit better informed about dental implants. We could perhaps go on and on with this discussion tonight, but at this point in time, it's time to conclude. So again, I want to thank all the panelists for working with me to generate this webinar, and they have done a wonderful job of sharing their expertise. I will now return you to our Surgeon General, Brother Dr. Jeffrey Sterling.
Well, good evening. I have absolutely nothing to add. That was just a phenomenal presentation, and I also want to compliment the audience for a series of phenomenal questions. On behalf of Brother Dr. Willis Lonzo III, the General President of Alpha Phi Alpha Fraternity, and the Deputy Surgeon Generals and the Board of Directors, thank you for coming this evening. Join us again in this space 2 weeks from this evening on February 2nd, where we will be talking about family planning, things such as power of attorney, durable wills, and other considerations. We want you to plan for those circumstances so that you aren't caught off guard, as is too often the case. Thank you for joining us. Have a pleasant evening. Be safe and be well. Good night.